unmute themselves. Meeting is being recorded. It will be posted on our Facebook page. So formally welcome to the 85th edition running of Thursday Musings. Today we have our senior Nandani ma'am. She'll talk on antipsychotics in first episode. How much, how long, how often? Very pertinent clinical questions. Next slide, please. I'm handing over the session to the chairman of the program, Professor Dr. Tufan Pati sir. He's from Cuttack. Sir, over to you.
Thank you, Alim. Thank you very much. And next slide, please. We have got two vibrant moderators with whom you have interacted before the formal starting, and Dr. Amrit Patadasi and Dr. Alim Siddiqui. Both are vibrant young leaders of Indian Psychiatric Society and two pillars of Thursday Musings, which is going to complete its 100th episode after 15 episodes from this. And I wish a happy Holi to everyone, all of you who are here and who are going to join very soon. And we are expecting not less than 200 attendants to all of them. And can I have the next slide, please? I have the pleasure to introduce my very dear friend, Dr. G. Prasad Rao of Asa Hospital, Hyderabad. Asa Hospital has been an exemplary hospital private setup in India. And Dr. Prasad Rao had been the president of IPS. He was the deputy editor of Indian Journal of Psychiatry. He is the president of Indian Association of Geriatric Mental Health, president of Indian Association of Private Secretary. He is the president of Society for Bipolar Disorders of India. He is president of Indian Association of Biological Psychiatry. He is president-elect of Asian Federation of Psychiatric Associations. Welcome, Dr. Prasad Rao. Welcome. Next, Dr. Sydney Moriangthem. He is our other chairperson. Now he is additional professor of psychiatry in NIMHANS, Bangalore. Current areas of work and research: bipolar disorders, epigenetics, emergency psychiatry, forensic psychiatry, and telemedicine. His professional education is postdoctoral fellowship, December 5th, 2015 to June 2016, University of Florida, US, and Gainesville Valley, Florida, USA. Postgraduate psychiatric training, MD Psychiatry 2004 to 2007, Postgraduate Institute of Medical Education Research, Chandigarh. Professional experience, additional professor of psychiatry, NIMHANS, Bangalore. He is continuing associate professor, NIMHANS, Bangalore, up to 1st July 2016, assistant professor up to 30th June, assistant professor in Chettinad Hospital and Research Center, Tamil Nadu, from 5th April to 25 January 2013. He had been the senior resident in PGI near Chandigarh. Awards and honors: gold medal and highest honors in otolaryngology, and honors in anatomy, and gold medal in pharmacology, and highest mark in medicine. With this, I welcome to this meeting Dr. Sydney Moriangthem. Now, having introduced the chairpersons, I don't want to delay the process, and the proceedings forward belong to the chairpersons, Dr. Prasad Rao and Dr. Sydney Moriangthem. Please take over.
Rao sir, you have to unmute yourself. Chintan, stop the slide so that Rao sir can introduce the topic. Please make Dr. Prasad Rao as co-host. He's not a co-host, I see.
Also Dr. Sydney.
And Sydney, yeah. Rao sir, you can go ahead.
Hope I'm audible.
Yes, sir.
Yeah. First of all, it's real great pleasure today. And as you can see in the slides, I start with Happy Holi. I also am very happy that with me is Dr. Sydney. And do you know what is common between both of us? We both are from PGI Chandigarh. Both were from, I think I'm a medal winner, and I think Sydney is also a medal winner in PGI for his MD. Then what more? There is a third thing that both PGIs as moderators are chairing a person who post-graduated from CIP Ranchi and holding a great post in United Kingdom. So it's my pleasure to just introduce the topic. As you can see in this slide, there are so many oranges, or I just put on oranges here, but there are multiple things. How to choose your antipsychotic for your first episode patients. I'm sure our learned speaker, Nandini, is going to really elaborate. But I thought, as a young postgraduate student in PGI, I promise you I had only about 5 molecules to offer to my patients. Haloperidol, trifluoperazine, chlorpromazine, thioridazine, and towards the later part, I did get pimozite. And obviously, whoever the patient comes, psychosis, whatever stage we had, I think today's world is not that. The most important thing today is that the treatment of untreated illness during and the first time when the patient comes. I think in today's lecture, I'm sure we are focusing mostly on the pharmacotherapy as the title suggests. Not that the psychosocial treatments are anyway less, nor adherence factors. But for me, how to choose antipsychotics, how much to give, how long to give, has always been a lifelong issues to handle with my patients. And I'm sure it is true to everyone. Fortunately or unfortunately, as we evolved, we now look schizophrenia into the 6 phenotypes. Whether it is the first psychotic episode or the subsequent recurrent episodes, what you find obviously is a cluster of these phenotypes, be it for positive symptoms, motor symptoms, or what it was oldly called as catatonic symptoms, mood symptoms, cognitive deficits, disorganization, and negative symptoms. As you find in this slide, I kept negative symptoms in yellow because truly, we really don't know whether the pharmacotherapy will really help. And today, the research is not throwing up any good molecules specifically for this chronic deficit state. For cognitive deficits, for mood symptoms, there are obvious choices. So, for me, if I have to start a treatment for my patient of psychosis, the first episode or otherwise, what is that we are aiming? I think we are looking at bringing about symptomatic response to start with, preventing relapse, achieving remission, and obviously attaining a functional recovery and remission for a long time. This is what Jim Kane has really asserted in one of the beautiful editorials in the supplement of Journal of Clinical Psychiatry. I just want to close and open this topic to Nandini before my dear friend Sydney, my young friend I would call Sydney. Sydney is much younger to me. I think he agrees to that. Starting from chlorpromazine, you have haloperidol and a set of molindon and loxapine. And I kept this as a green, the clozapine. Indeed, Hock and Polatin has defined clozapine as the atypical antipsychotic for the first time. And all the molecules from this to the most recent molecule which I've shown here, the primavaserine, are all atypical antipsychotics. And some of the purists do talk about atypical antipsychotics and atypical antipsychotics to label the molecules which came after 2010, starting from aripiprazole, lurasidone, brexpiprazole, cariprazine, and primavaserine. I would just close my opening address to just say, be it depression, be it positive symptoms, be it any psychotic symptoms, Thomas Schlutt in the publications, in the meta-analytic publications of both 2009 and 2013, comes out that these are the 5, 6 top molecules: amisulpride, clozapine, olanzapine, aripiprazole, and quetiapine. There is a subtle difference between the positive and negative symptoms. Clozapine still holds good, but for depression, obviously, amisulpride and clozapine seems to have evidence. I will close my presentation and welcome and open the topic. And I'm sure during the next 35 to 40 minutes, Nandini is going to open up a large canvas focusing on the evidence. I would come in a later part to comment on the efficacy part and tolerability and other factors. I would now invite my friend Sydney to introduce our learned speaker from thousands of kilometers from this country, though her heart is from India, Professor Nandini Chakrabarti.
Good
Sydney.
evening, everyone. Sir, just a mild disclaimer. I was strictly very average in PGI. I'm not a medal holder like you. Yeah, and yeah, it's really an honor to be chairing the same session together, two PGIs from the same institute, with just a gap. Having said that, I completely agree with what Rao sir has just described. Look at the paper in 2006-07 when I was doing my postgrad, in 2019-20. What I can very confidently say is that, what are we really dealing with when we say first episode psychosis? Is it going to remain a psychosis? Is it going to migrate into some other disorder? And the outcome which was written a decade back and the outcome which is written now based on the meta-analysis doesn't seem to suggest that it has changed quite a lot. But we can uniformly agree that probably still today, yes, we have more data, more meta-analysis, more systemic reviews, but we are not still very clear of what would be the best way forward. And yes, epigenetics has tried to define the disorder a little more. We have more neuroimaging as an add-on. Maybe we would call it evidence to suggest that we understand better. But yeah, there is no straightforward answer. So I believe with this, Dr. Chakrabarti, Professor, it's really an honor to
introduce
have you here.
Dr. Chakrabarti.
Yeah.
Yes.
So just let me introduce. I'm just reading out from the slide. Please don't mind. My name is a consultant psychiatrist in an early intervention in psychosis, Leicestershire Partnership NHS Trust, and an honorary professor in the University of Leicester, Department of Health Sciences. She's holding the position of an immediate dean for equivalence at the Royal College of Psychiatrists and the national lead for recruitment in psychiatry with the Royal College and the Health Education England. Professor Chakrabarti is also the secretary for International Scan Panel and scanner for the University of Leicester. She is an associate dean for the College of Equivalence since 2016, and Dr. Chakrabarti has led the work on CESR in psychiatry, training both applicants and evaluators, advising the NHS Trust about the correct way to support applicants and mentors. And she's also a member lead in CALC in the college and has a role in setting up new contents. In the UK, ma'am is a member of the GMC PLAB 1 panel and PLAB 2 examiner. She has delivered remote training in India and Palestine, and she has had psychiatrists doing clinical assessment with her from many different places like Egypt, Nigeria, Sri Lanka, Nepal, India, and Cuba. And ma'am has a special interest in patient experience and psychotic symptomatology. She has held local educator roles, including college tutor, training program director, and MRC site courses organizer, and continues active educational and clinical supervisor. She's also an active reviewer of several journals and herself published in Early Intervention in Psychosis, Global Mental Health, Managing Stress in Doctors, and COVID. Right. Professor Chakrabarti, ma'am, I'm very sorry if there's any mistake in describing the role that you have been in the past or currently right now, because some of them are abbreviations and I was not very sure how to, do the best way forward. But yeah, it's really an honor to have you here. Kindly start. I think Professor Chakrabarti is still in mute mode.
Hello, good evening, everybody, and happy Holi. Thank you very much for those kind introductions. And to start off, before I start sharing my slides, I'd like to talk a bit more about the background and why I chose this talk. And they say that never judge a book by its cover. And so, surprise, surprise, actually, most of my talk today is not about pharmacology or pharmacotherapy. And I hope that, this talk will generate discussion, because if I just copy pasted a lot of things from a pharmacology book, I'd put all of you to sleep. It's pretty late in the evening in India over there. So I want a stimulating discussion on what might be a very ethical and debatable part of psychiatry. We all have to be aware that psychiatry is probably the most politicized and political area within all medical specialties. We deal with a lot more of course, we deal with emotions. Psychiatry is about dealing with mood and emotions, but it's emotions on a more human aspect. So before I start sharing my slides, let me talk a bit more about the service I work in. I work in a team called Early Intervention in Psychosis. And it's a specialized team, it's a specialized setup present in the United Kingdom. It's also present in many other Western countries, in Canada, in Australia. Australia is the birthplace of early intervention in psychosis. And the principles appear to be very straightforward. Treat first episode of psychosis early, and you're going to get a better prognosis in the patient in the years to come. Seems pretty intuitive, seems pretty common sense. Why do you even need a study to prove that? But people did lots of studies because you need evidence to invest money in a service. And so money was invested. The teams in UK date back to the 1990s, most of them around 1999, with an initiative called the National Service Framework, which was a government initiative at that time, which said, let us set up teams for the most vulnerable patients, invest money in the most vulnerable patients, and that will save money for NHS in the future. Everything has to be tied up with money. And then what happened is first episode psychosis and early intervention in psychosis turned out to be not just a treatment service, it turned out to be a movement. And not just a movement, a very youth-focused movement. Suddenly the ethos of these teams were, these are these young people presenting with serious mental illness, where psychosis has thrown them completely off chart from their lives. We need to bring them back to their normal lives. And then I noticed, like Chinese whispers, it became a bit like, oh, there can be diagnostic uncertainty in first episode psychosis. Then the culture shifted to, because there's diagnostic uncertainty, perhaps we shouldn't diagnose at all. And to my surprise, when I joined as a consultant in this team in 2009, and coming from my Indian background, where I learned most of my psychopathology and pharmacology, I found most people had a diagnosis of acute psychosis. No differentiation, delusional disorder, schizophrenia, schizoaffective, bipolar, nothing. And CIP had grounded me in, you've got to diagnose what you are treating first. So it came as a bit of a shock over there. And I started changing the team culture, that you've got to understand what you're dealing with. Bipolar, schizophrenia, delusional disorder, acute and transient psychosis, they still have meaning. And so time has plodded on, and I'm going to start off by saying that, when we talk about choices, we've talked about various antipsychotics, but the culture today, the movement today is, does there have to be an antipsychotic at all? And that's where I'm going to present the evidence, not saying whether I'm for or against the movement, but let's look at the evidence together, just what the papers have published, and then come up to what the nice guidelines say, and then we can have a discussion at the end. So that's basically the theme, the context where I come from. Okay. So I kept it simple. Antipsychotics in first episode psychosis, how much, how often, how long, but within the how much, the question is at all, is also one of the options over there. But I'll tell you what the world is thinking now. This was a headline in BBC, February 2021. And you know how people read newspapers. People don't read the evidence. People don't read the fine print. The headlines strike out there. How Norway is offering drug-free treatment to people with psychosis. Screaming headlines in February 2021. I read through it and I thought, well, it's not telling me anything which is absolutely new. It's not like it is a revolutionary treatment of psychosis when you ultimately look between the lines. But that headline was enough for one of the journals where I'm on the editorial board, for the managing editor to come to me and say, Nandini, will you write a narrative review in response to this headline? And that got me searching that why are people thinking like this? Where is this movement coming from? And then I read and found more. It's not a new thing. 2021, yes, suddenly BBC starts this headline, but actually what was happening in Norway was happening a lot earlier. In 2015, the Norwegian health minister, so remember, a lawmaker, a politician, not a health person, not a health professional, following the advice of user organizations, so this is patient organizations, urged the 4 regional health authorities in Norway to offer medication-free treatment to persons experiencing psychosis. And in 2016, the Western Norway Regional Health Authority started this. They started to integrate more psychosocial interventions. And the first news report was from 2017 about a unit at Asgard Psychiatric Hospital in Tromsø, where, again, a very striking, a very dramatic headline, the door to a revolution in psychiatry cracks open. And then I tried to look at the evidence. You know, if they have been around since 2016, 2017, what has been the evidence in these 5 years about how efficacious this treatment is? And all I could find was this one paper. And it was a qualitative study taking the views of the patients of the unit. It was just qualitative interviews with these patients. So there weren't really any functional outcomes. It says, over here, it means so much for me to have a choice. And it does make us think that the choice is not ours as a clinician. It's not our lives being influenced about whether an antipsychotic works or not, whether somebody comes back to a functioning life or not. Let us remember that this is the life of the patient we are talking about. And them feeling involved in a decision, involved in a choice is also very important. And the highlights of that study was that, as I said, it was a qualitative study. It was first person patient perspective, 10 in-depth semi-structured interviews, and the findings indicated that integrating more evidence-based psychosocial interventions led to learning experiences, and there was discontinuation of medication, appeared to support participants' increase in self-agency and motivation. But my reading of this is that it was a very small unit. It was very select patients. It was patients who were willing to engage with services. So they agreed that there was something wrong with them. And as a consultant psychiatrist in an early intervention in psychosis unit for over 10 years now, I can say that a lot of my patients would not even start by agreeing that there was anything wrong with them. So for anybody to even engage in talking therapies and psychosocial intervention, there must be some insight. So it was a very select group of patients. And this was the man, Magnus Hold, who was in charge of the Tromsø unit. If I'm not mistaken, he is a psychiatrist, and I think there are some YouTube videos he has. It might be worth just looking at the other side of the picture, having a look at, you know, what he says. Okay, and the other things in Scandinavian countries. So the other movement, the other intervention to be aware of is open dialogue. So open dialogue is not exactly a therapy. It's not a new kind of therapy added to DBT, CBT, psychoanalytic therapy. It is an approach. It's a family and social network approach to first episode psychosis care. And it started in Lapland. And there's more literature on it. But the interesting thing is that our NHS Trust in Leicester has recently invested quite a bit in training at least 30 professionals across different teams and across different professions, nurses, psychiatrists, healthcare support workers, psychologists in open dialogue. So I've just done my first training session. I've approached it with an open mind to see what exactly they say open dialogue is. I'm still getting to grips with what exactly it entails if I'm going to offer open dialogue rather than psychotherapy, and it's early days. This is copy pasted from the opendialogueapproach.co.uk website. You can have a look at their website. These are the people who are actually offering us the training. And it says that it is a philosophical and theoretical approach to people experiencing mental health crisis. It's a system of care developed in Western Lapland, in Finland, in the 1980s, they claim. And I've not found many references to what they are saying here. I must state that it's all stated there in fact that this is what we found, but I'm not very sure about their background referencing over here. And what they're saying that it's not an alternative. This is the psychiatric service. So we have a team over there. Whenever somebody is in crisis, we go out as a team, visit them at home, involve the patient. We don't drag them into hospital. We don't start giving them medication. We talk and we have this open dialogue, and that will cure patients and they will have better prognosis in future. That's their claim. However, not everybody believes, not everybody agrees. Another study, I found the reference over there, 23 semi-structured qualitative interviews, but this time of Norwegian psychiatrists regarding medication-free treatment for psychosis, found that these psychiatrists considered medication-free treatment as an unscientific option for a stigmatized patient group, and they believe that the advent of such a program is due to proposals from some dissatisfied users and their supporters, and not from the majority of patients. So there is an alternative view. It's not a consensus. It's not that Scandinavian countries have all changed. Everybody there has changed their opinion. And then I looked into, okay, so we're talking about how long do we continue an antipsychotic? How long do people achieve remission? How many of our patients do actually achieve remission? What does history say? And we have data, we have information from pre-antipsychotic times, as early as 1939, where a study from Dr. Stalker at the University of Edinburgh published outcome data on quite a substantial number, 3,551 patients. And he showed that 21% were in complete remission or social remission, that they were functioning. 5% were improved and living at home. So the natural course of schizophrenia, or whatever was diagnosed as schizophrenia at the early part of the 20th century, in the natural course of illness, around 20 to 25% will achieve significant remission. And that happens without medication. Even if you don't treat them, they will get better in some kind of way. 1978, Dr. Stephens in Maryland Psychiatric Research Center did a summary of 25 schizophrenia outcome studies. Patients had been followed for at least 10 years. So quite robust data, quite spread out. Again, 29% of patients were in complete remission, although this varied widely among studies, depended on the initial sample, whether this was good prognosis or bad prognosis, individuals with a slow onset, negative symptoms, which we know traditionally were the good prognostic, bad prognostic outcome variants. But again, the figure coming up is around 29% of patients achieve complete remission. So, antipsychotics versus no antipsychotics. Dr. Stocker's study showed before antipsychotics had been introduced, 67% of his patients were rated as unimproved. So of the patients who were not on antipsychotics, either they got better in the natural course of events, but the rest were unimproved. You know, the proportion who got better were fine, but the proportion who didn't get better, yes, they remained unwell. In the later study by Stevens, the average number of patients rated as unimproved was 44%. So remember, this is the group which was treated. So if you look at the proportions, it does look like if you have a population of patients with antipsychotic treatment and you have a group of patients without antipsychotic treatment, the group with treatment does have a larger proportion who are, improved. So, 44% was unimproved when they were still on antipsychotics, whereas in this case, without antipsychotics, 67% remained unimproved. There's these other studies I wanted to bring forward just to, again, give you that political flavor of there is quite a strong lobby out there for treating people with schizophrenia, stroke, psychosis without medication. This one actually comes from Nottingham, quite close to home actually. And from this is 2008, it talks about the soteria paradigm for treatment of people with diagnosed with schizophrenia. Interestingly, with these studies, what I find is they'll often say schizophrenia on the headline, but then when you look into the paper, you understand that they're talking not only about schizophrenia, it's schizophrenia spectrum disorders. And what is included in schizophrenia spectrum is really wide. You're talking about drug-induced psychosis, acute and transient psychosis. You're talking about anybody who says, I hear voices, even if they are quasi-psychotic episodes in people with borderline personality disorder. Lots of people where even I would say that let's perhaps admit or support, but, withhold the antipsychotic straight away, or people where I would say that, I'm not going to give an antipsychotic forever, if at all. So the treatment of schizophrenia is not the same as treatment with schizophrenia spectrum disorders. And so these papers need to be read carefully. We need to see that it actually says or does what it says in the headline on the cover. And there are other studies as well. So this is antipsychotic medication and remission of psychotic symptoms 10 years after a first episode psychosis, quite a relatively recent paper. And what did they found? And they found that 61% of the patients from the original cohort attended the 10-year follow-up. 30% of these had remission of psychotic symptoms with no current antipsychotic medication. So year on year, actually what you're finding is this 20 to 30% number comes across the centuries, across the decades. What boils down is 20 to 30% of patients, even with a proper diagnosis of schizophrenia, will come off medication and remain well. Whereas with the others, then your choice is, do you treat or you don't treat this 70 to 80%, and we will see the the later papers. I won't preempt that, and you tell me what you feel about this rest 70 to 80%. However, in these people who came off medication, the outcome is associated with female gender, high global functioning scores, participation in the labor market, absence of substance abuse. Again, not very surprising, prognostic factors that we mostly would have predicted. And it gives us a little bit of idea about the kind of people we can take off medication, though statistics is sometimes difficult to apply to an individual patient sitting in front of you. Now, antipsychotic discontinuation and recovery, chicken or egg. So there's this study that, Harrow et al. Had published. And what they said was, long-term effects of antipsychotic medication. And the article concluded that those who are not prescribed antipsychotic medication are more likely to experience episodes of recovery. And that after 2 years, antipsychotics no longer reduce psychotic symptoms, and participants not on antipsychotics perform better. But then here is this, letter contradicting it and saying it's a chicken and egg thing. Are these people doing better because you took them off an antipsychotic? Or is it because they were doing better, because their symptoms had resolved, that their psychiatrist decided, let's give a trial without medication? And it makes perfect sense, that contradiction. And with that, I would say something along the lines of, so people who are under the care of psychiatrists have worse mental health than people who are not under the care of psychiatrists. But that doesn't mean that we are doing a bad job. People come to us because they have difficulties with their mental health issues, serious mental health issues. People who have better mental health out in the community don't need to come to a psychiatrist or psychologist. But that doesn't mean that being under the care of a psychiatrist is bad for your mental health. The chicken and egg situation. And that's the problem with some of the papers which say people not on antipsychotic medication are doing a lot better. So what does this one say from Chicago? Does treatment of schizophrenia with antipsychotic medications eliminate or reduce psychosis? 20-year study. I think this one was the one which, this is the Harrow et al. Paper which was being talked about, where they said that, more than 70% of people with schizophrenia continuously prescribed antipsychotics experience psychotic activity. Well, if somebody was continuing to experience psychosis, that's when I would give them antipsychotics. It's when their psychotic symptoms reduce that I would take them off their antipsychotic, the chicken and egg effect. Now, what does this one say? So this is from Australia. Psychosocial intervention with or without antipsychotic medication for first episode psychosis. Now, I'll send you the slides and you'll have all the references to read these papers in detail all over again. But again, if I try and summarize this paper again comes from, the birthplace of early intervention in psychosis. Patrick McGorry, the father of first episode psychosis treatment, early intervention. And when they selected patients for this study, again, they said, without antipsychotic medication did great, but their inclusion criteria was very restricted. So people had to be calm, they had to be engaging, they had to be non-risky. So really the acutely unwell psychotic patient being aggressive, violent, presenting with risks to themselves or others are never included in these trials. And this comes from Finland. Scandinavian countries are very well known in having huge data sets, lots of continued follow-up studies. And this was a 20-year follow-up study of physical morbidity and mortality in relationship to antipsychotic treatment in over 60,000 patients. Impressive number over here, over 20 years. And remember, when we are talking about all this criticism of antipsychotic medication, a lot of that criticism is also to do with, the metabolic health monitors and, what we see in terms of metabolic syndrome. But what they found was, they found that in the cumulative mortality rates in 20 years, the mortality rates were 46.2% for no antipsychotic use, 25.7% for any antipsychotic use, 15.6% for clozapine use alone, right? So these data suggest that long-term antipsychotic use does not increase severe physical morbidity leading to hospitalization. Clear, hard, quantitative data, which shows that antipsychotics work. And it's not about only resolution of symptoms. We are talking about a very significant parameter, because there is, again, a lot of data there that people diagnosed with schizophrenia die much earlier than general population. They die at least 20 to 25 years earlier than what the average mortality death would be for their population, like for like. And against that, this study throws up, quite a bit of debate and discussion around no, antipsychotics are not to be straight away thrown away. I work in the UK, as I said, early intervention in psychosis. What do my nice guidelines tell me? What do my nice guidelines tell me about pharmacology and psychosocial intervention? So according to the current NICE guidelines, early intervention in psychosis services should aim to provide a full range of pharmacological, psychological, social, occupational, educational interventions for people with psychosis consistent with this guideline. Use oral antipsychotic medication in conjunction with psychological interventions, where they talk about CBT, family therapy, and art therapy. So, and the choices, I must say, are very interesting. And we have had, postgraduate academic meetings where you get people sometimes really, really divided on this. I wouldn't tell you straight away what I think about this. I'd like to hear from you what you think about it, because this is what they say. Offer CBT to all people with psychosis or schizophrenia. This can be started during the acute phase, later, including in patient settings. Offer family intervention to all patients with psychosis or schizophrenia. Consider offering arts therapy to all patients with psychosis or schizophrenia. But do not offer counseling and supportive psychotherapy. And however, take service user preferences. So, okay, if the service user likes it, then you can give supportive psychotherapy. Very interestingly, do not offer adherence therapy as a specific intervention for people with psychosis or schizophrenia. Do not routinely offer social skills training as a specific intervention. I would really love to hear what the room has to say about that. Okay, so coming back to the duration and antipsychotic use, where do we go from there? There is this quite interesting review that I came across about, which admits that there are contradictory messages regarding the necessity of long-term antipsychotic treatment after first episode psychosis. And it talks about challenging the minimum effective antipsychotic dose. And the results that they found over there was that 81 patients, first episode psychosis, 67.9 had follow-up information, majority non-effective. They found that 36.4 were in full-time employment, education. So again, it comes to that 20 to 30% kind of figure of people who do well, out of which 15 patients received antipsychotics not more than the minimum effective dose. So you can actually take the medication down to a very, very minimum level. They're talking about chlorpromazine equivalents of 200 milligrams per day. And 10 out of these 55 patients received very low dose antipsychotics, even below that chlorpromazine equivalent, but this significantly correlated to good functioning. Being male, having a history of hospitalization, being on clozapine correlated to poorer functioning. Antipsychotic free status achieved in only 2 out of 55 patients. So very, very few within this. Now, again, over here, we are talking about first episode psychosis. And the other point I would like the room to think about is, this entity of first episode psychosis. First episode psychosis seems to have gathered a life of its own. It's not an ICD or DSM diagnosis. We have always tried to be specific about, what kind of psychosis we are talking about. And I think that's important in kind of giving evidence to the patient of what are the relapse rates in particular illnesses, trying to talk about the risks, and benefits of coming off medication. But first episode psychosis is everything from, as I said, acute and transient brief psychotic episode to somebody who has suffered with schizophrenia untreated for the last 5 years. And how we can put all that in one basket beats me. And schizophrenia itself is a very heterogeneous illness. We cannot say pathologically, very confidently, that we are treating the same brain pathology when we are talking about schizophrenia. Hebephrenic schizophrenia is very different from paranoid schizophrenia to catatonic schizophrenia. So we are already dealing with a very heterogeneous bunch, and to widen the heterogeneity to first episode psychosis, including everything and anything over there, is, does make it very difficult to interpret the data. Gosh, I'm not sure what's happened to my slide over here. Okay, but basically this slide is about an ongoing study. It's not a study that has been completed, but we hope that when this study is done, then it is called the Hamlet trial, and they are going to look at dose reduction versus discontinuation. And this is going to be completed in 2026. So we'll probably get the data, the actual results, almost 10 years from now. But the question about how long do we continue an antipsychotic, which antipsychotic do we give, continues to go on there. I don't think anybody has a clear answer. Okay. Right, so this was my review paper. I will send the PDF one around. That was a narrative response to BBC's headline, as I said, and it has all those thoughts, and all the references are listed there. But what I think, going to these various different teaching sessions about open dialogue and soteria paradigm, etc., is that we're almost like a community who are the blind men in a room feeling different parts of the elephant. And it's important that we listen to each other, and important that we bring the research happening in different parts together in one holistic way. Because there's huge amounts of research happening in the neuro analytical field. And I remember going to a session now a couple of years ago. It's not still in clinical practice, but basically somebody telling us that in a couple of years, in an ideal scenario, we'll be able to do brain images and say exactly what kind of antipsychotic to use depending on, which area of the brain is affected. And by doing brain imaging, know exactly when to stop an antipsychotic or how long to continue it. And that we would not even have to even do a long diagnostic interview with our patients. We can, the patient comes in, we get the chief complaints, do the scan, and we can diagnose whether this is schizophrenia or bipolar or schizoaffective disorder, etc., etc. I think we are a long way away from that. And what we do with our patients, the trust that they have with us will go a long way in assuring their compliance. We cannot be pinning down people and injecting them, throughout their lives. So it's okay to have that research, that neuroscience behind us, and it's important. It's important to look at other views, but it's dangerous to go on either extreme. So my conclusions over here are, there is little doubt that a subset of patients with schizophrenia will eventually come off medication and remain symptom-free without antipsychotics for the rest of their lives. This figure varies between 20 to 30% in various studies. So effectively, 70 to 80% of patients with schizophrenia without an antipsychotic will relapse. When my patients ask me, what are the chances of relapse if I come off medication? And we are absolutely sure the diagnosis is schizophrenia, box standard ICD-DSM defined schizophrenia. And I say, it is 70 to 80%. But there is a 20 to 30% that we can take you off medication after a year. Most guidelines in first episode psychosis, when they talk about giving antipsychotic medication, they say continue it for at least a year of stability after the first episode psychosis. But after a year starts the period of discussion, which depends very much on individual symptoms, past history, risks, patient choice, etc. So studies which consider the treatment of psychosis without antipsychotic medication, this is my observation from my review, usually consider patients with heterogeneous diagnoses. So I'm yet to see a paper where they have taken proper criteria, diagnosed schizophrenia and stuck with it. No, even if they say schizophrenia on the headline, it all becomes a bit vague and wishy-washy when they do the actual inclusion criteria. They're talking about patients with low risk and relatively stable clinical state. There are no head-to-head, double-blind, randomized controlled trials of antipsychotic medication versus psychosocial interventions in a group of patients with specific diagnosis of schizophrenia, acute presentations with high risk. And I don't think there will ever be. I don't think people will be brave enough to do that. In spite of all the talk around, we can do open dialogue and we can treat people without medication, etc. When it comes to this, I will be very surprised. So considering patients who have come off antipsychotic medication or even recovered without medication as evidence that all patients with psychosis can be treated without antipsychotic medication, I think is a very political and a very dangerous conclusion. There is a difference between psychosis and schizophrenia, which should not be forgotten. The prognosis of drug-induced psychotic episode is not the same as schizophrenia, and mixing up terminologies is unhelpful. That's where my love of psychopathology and phenomenology also comes in. I think when we diagnose first-rank symptoms, we've got to be very clear about our psychopathology and what we are talking about. If we become vague about our symptomatology, that's when we become vague about diagnoses as well. And medication and psychosocial interventions can work together. They do not need to compete. We don't need to make this a debate of one versus the other. We can remain holistic, but as psychiatrists, as senior clinicians, I think we need to be aware of the debates, because this is what our patients will read on the media. This is what our patients will research on the internet. This is what they will come to you in clinic with. You know, you'll have families saying, this is what the media is saying, this is what BBC is saying, and yet you are telling me this. So we need to be armed with the evidence in order to explain to them what is exactly happening. So I'll stop sharing my slides there and conclude a bit about what I do with antipsychotics, and it's very simple. So with first episode psychosis, depending on the duration of the illness, if people have come with a very acute, 4-week illness, or it's clearly drug-induced psychosis, then I do insist that we continue the medication for at least 1 year. After 1 year, it depends on how long they've been unwell before that and how severe, how much the risks were. And actually, I have patients who are very reluctant to come off medication, even if I tell them that, look, I think very unlikely you will have another episode if you keep off the drugs, if you manage your stress, because we know that stress had a big part to play in your episode, stress, vulnerability, etc. You don't have family history, it's not ever happened before, etc., etc. And yet it is sometimes patient choice. No, keep me on a low dose of medication, and we should respect that. There are others where you will have to take a decision with them to stop the medication a bit earlier, because the side effects are so bad. If they don't achieve quality of life, if they don't achieve functionality, and if they are asymptomatic, and if it looks like the advantages of giving them medication is outweighed by the side effects and the risks, then take them off. What medication do you give them? Of course, the second generation antipsychotics. So aripiprazole, lurasidone, cariprazine, the recent advent on the on the UK market, is very popular. Offering depots not just as a punishment for non-compliance, but actually for quality of life. So we, even if patients are compliant, we like telling them that, if you're on aripiprazole, you can switch to a monthly injection. It's a lot more convenient than being on tablets. Do you want that? So that, it's not just a punishment. If you don't take your tablets, I'm going to put you on an injection. That shouldn't be the approach. Then with paliperidone, Trevicta, 3 monthly, again, putting that offer over there that, rather than taking risperidone tablets every day, shall we gradually build up to that. We get a lot of patients from the inpatient setting, at least in Leicester, we are noticing on flupentixol. And the reason why that happens is that people are very acutely unwell. They won't take tablets. So if they don't take tablets, they can't be started on aripiprazole. They can't be started on, risperidone, Consta, paliperidone, etc. So flupentixol, give them a test dose and then give them a respectable amount so that they can come out on it. But usually then they have extrapyramidal side effects, and I have never continued the patient long-term on flupentixol. If they need to continue, we usually switch over. But unless there are very good reasons, I think any first presentation, including a proper diagnosis of schizophrenia, probably deserves at least one trial of medication with the full explanation of risks and benefits. And then if they are well, they are well. If it happens a second time, I usually advise them that, look, if it's happened a second time, it's very likely that it will happen a third time. When you're talking about schizoaffective or bipolar episodic illnesses, then a lot of other factors come into play. Some people with bipolar illness, I notice, relapse the moment you take them off medication. There are others who will have very classic annual episodes. There are others where you can actually see the classic textbook episodes coming closer and closer together. So if somebody's having an episode every 5 years and the episode happens only for 3 weeks, then you've got to think, do they need to be on long-term medication, whether it's antipsychotic or mood stabilizer? If it's just one episode every 5 years, can we manage? Can we educate them that whenever there are early relapse signs, we put you on medication for a couple of months and you'll be fine? So that's kind of my general thinking around medication and the other debates around it, and looking forward to further discussion. Thank you.
Okay, Nandini, thank you. Thank you for really opening certain of the, I would say, certain insights which most of the senior clinicians do have. And I would start first arguing that Nandini did pick up a kind of a good article, obviously from because she's a reviewer and all, and brought out the insight about can we stop antipsychotics for some of my patients. But then, as a astute clinician, and I liked her initial first two statements. She talked about politicized and she talked about emotional nature of it. Having said this, the 2-3 reviews or 2-3 articles clearly point out, and now I go back to my teacher Mohan Isaac, who is in this group here. He put a pertinent question: are we talking about a single schizophrenia? Obviously not. Obviously not. And the stories which you brought out about good prognosis, and I would now go back to my one of my good teacher who actually wanted in ICD is none other than Narendra Vik, our professor of PGI and then in AIMS. He tried his hard and he tried to argue about an acute psychosis which has a good prognosis in India and developing countries, and there should be a criteria. Having said that, I have worked and I run my schizophrenia clinic for the last 30 years, and I have been involved in the drug trials and I've been involved in patient treatment and all. I would argue, yes, this fact of 15 to 20%, and I would again go back to PGI's research. In between 81 and 90, three centers, a WHO guided trial, had took acute psychosis, the one which you said, and the figures, everything matches. Like our Agra center in the IPSS study, what we found is that still there is a group of patients, but I think I have a wonderful questions in the group which asked, can you tell us which are the patients whom we can stop? Unfortunately, the answer today is we don't know. I can also tell over the 3 decades experience of my schizophrenia clinic, patients do stop medicines in spite of your lot of whatever you call as psychoeducation, family education, etc. In this country, I'm sure all the clinicians will agree with that. This 15 to 30% of good prognosis schizophrenia is well known. In fact, our M.L. Kreplin, the father of psychiatry, in his neatly book, I have gone through his book, the English translation though, very clearly talks about this good prognosis psychosis and total remission in schizophrenia. Mind you, he differentiated dementia praecoxy and manic depressive insanity. Having said that, I think a lot of water flowed in the Ganges at this point of time. When to stop is a great question. I think it will be almost all clinicians, you would say the best thing to have in their hand. Okay, I'll do a blood test or I'll do an MRI and say, okay, this patient can be stopped. Sorry, we are quite far away from that. And I also think and I followed the McGorry's almost, I think right now around 67 or so papers, right from his initial papers. And I would really want Mohan Isaac to comment. He's here in this group, I think, because me and Mohan Isaac had a lot of discussions on this sometimes. The basic thing, what I would say, is the stability of diagnosis. And during our times, I'm talking of between 80s to 2000, there were at least 20 papers in the best journals of psychiatry which talk about how schizophrenia changed to manic depressive psychosis. Do you remember this was the table? And once the DSM came, they talked about mood disorders and bipolar. So that is part of the thing, but I still think schizophrenia if you talk about schizophrenia, it is so multiple phenotype with multiple prognosis. And of course, as a clinician, I would think I'm always, though an optimistic psychiatrist and a psychopharmacologist, I'm a basic researcher in the drug trials and I've done a lot of things. I would be very careful to say, and I'm also part of the authors for the IPS guidelines for schizophrenia. What we very carefully worded for the acute psychosis portion is watch the patient for a longer period, use medication, use psychosocial. These are the guidelines from the Indian Psychiatric Society. So I think one thing is First of all, I was a bit dissatisfied initially with your first two comments when you said, because I opened up with some kind of a thing expecting something of psychopharmacology, but it was totally different, pleasantly so. And I'm sure a lot of people, you have given the evidence from Norway and all, but again, you pointed out very clearly they are not a good, they are quite heterogeneous and probably a good prognosis cases as well. So with this in mind, I think, and the newer concepts in this today's time, we talk about drug-induced psychosis, especially the cannabis role in the psychotic episodes. So there are a few more complexities today, and I think time has come. So before I open to the further comments, uh, I would request Sydney also to give his offer his comments, and then first, with the permission of all the team, first of all, we should thank Tufan and Amrut and Alim, as usual, to bring a speaker with a different insight, and to wake us up once again to, yes, to today's world in our practice, in Indian practice, everyone comes with a Google printout or a Google mobile showing me, why should I take medicines kind of thing. Are you sure about your diagnosis? So this is probably universal everywhere, and I don't think we can escape. And the newer generation is far more challenging for this. So with these brief comments, thank you very much, Nandini, and I hope there will definitely be a lot more. See, your topic is not as simple as, whether to give, how to stop, when to stop, as simple as that. Your topic is much more to look into each patient. And I would just close my last comment. We, since 2013, the World Psychiatric Association presidents are talking about personalized psychiatry. What it means, personalized psychiatry, is each patient of schizophrenia is different, or each patient of anxiety neurosis is different. You can't use the same. But to begin with, to tell our students, I think there are a lot of students in this group as well, there should be something to clearly say. And for me, if there is an acute psychotic episode with frank delusions, hallucinations, I go with what you say. I'll start with an antipsychotic. See, keep, as I gave in my slide, first slide, to quickly achieve remission, to maintain the remission, and to maintain and be in touch with the family, and use psychosocial and other methods for whenever they need it. And I also showed the slide of 6 phenotypes. And for me, each patient is a group of these 6 syndrome, at least at this point of time. I've not seen any seventh syndrome phenotype in my patients, but this I think I'm happy with it. Sydney, I would like you to comment.
Thank you, sir. Professor Nandini, it was really a nice presentation because honestly speaking, I was not sure what you'll be presenting. You said it, it's going to be a little bit different. We're on the same page. Dr. Amrit, Dr. Alim, can I just request you guys to take over? A lot of comments has come, and once we address the comments and responses in the house, then if there is time, then I'll try to co-answer with Professor Nandini. There are a lot of interesting findings. Some of the studies were really intriguing, and in fact, one of them was what I just read this afternoon, and it was quite nice.
I think we should
Thank
start with
you.
Dave's question. Any definite guidelines about whom not to give antipsychotics? Is there a mild to severe category? I think Nandini would answer that, but my own answer is that right now this concept itself is so not so as crystal clear as any one of us would understand. So I don't think there will be any guidelines for this. But the guideline, obviously, even in Indian Psychiatric Society, is take an individual approach with each of your patient and the family. Nandini?
I think the only point where I would not treat with an antipsychotic is if I'm very clear that it's a drug-induced psychotic episode and you can keep the patient safe until the drugs wash out of the body and the symptoms resolve. And there's two things to think about in treatment. Sometimes people will get better without treatment, but do you want to prolong their suffering? Acute and transient psychosis, by its nature, by its definition, again, symptoms will pass off. But do you want it to continue for 6 weeks when you can bring it down in 6 days? What are the risks involved over there? So if you have a setting where, the clear history is took cocaine 2 days ago and now is completely off their head, and you can just keep them on an inpatient setting treat them with perhaps, benzodiazepines, make sure that they have, they are in a safe environment, not hurting anybody else or themselves, and just let things, calm down with time without access to illicit drugs. That's the only situation I can think about where you would safely say no antipsychotics. The other situation, though, there have been some patients on my caseload where, people are very psychotic, and very psychotic meaning they have very steady, systematized delusions, they have some hallucinations, but they live very happily with them. And they don't present a risk to themselves or others. They have their own delusional world. And that has been continuing for years. And somehow they manage to function even with it. Mostly people with, the diagnosis would usually be between paranoid schizophrenia and delusional disorder. And there you've got to think very carefully about what are the benefits of treating at all. If this patient came out of their delusional world and then suddenly looked back and thought, oh my God, 10 years of my life I've been living a lie, then, what does it mean to them psychologically? Would they actually be happier and function in a way with their psychotic symptoms for the rest of their life? And there, do you actually need to treat them? Well, again, philosophical question, but on the top of my head, I can think about at least 2 patients out of the hundreds of people I've treated in over 10 years, where we actually took a joint decision to say, look, I don't agree with what you believe. I do think you're psychotic, but I do agree with you that you can live your life as you're living and I don't need to intervene. So off you go. And they haven't come back with any adverse events so far. Touch wood.
Thank you. I think each one of us might have similar guests. I request Mohan Isaac, sir, to offer some of the insights. He is the most respected teacher of psychiatry across the world, I would say right now. Sir?
Hello.
Meanwhile, yes, sir.
Yeah, I think I have unmuted. Thank you very much, Prasad, for asking me to say a few words. It has been a very, very nice presentation by Professor Chakraborty.
Thank
I
you.
was, like Prasad showed us few slides, and he, as a chairperson, took the liberty to predict what the speaker was going to speak. As he himself said at the end, he was a little disappointed because she did not say anything of that. He, in fact, started by saying that I am not going to talk about what antipsychotics, how long, etc., etc. But I must say that it has been a very well balanced talk. Taking the different extreme viewpoints, and in her wisdom and based on her clinical experience, she has given us as much of clarity as possible. I have put several questions in the chat box as I was listening. You don't have to answer it, but these were doubts which came up, and I thought I will put them in the chat box. The first one was, at what age do people get referred to in your particular unit? And how long do you assertively follow them up? 3 years, 5 years, longer? Because there's a lot of information about the early intervention psychosis field that if you don't assertively follow them up after a certain number of years, they are like any other treatment as usual kind of thing. That was a question. Then there were a couple of other questions, and I would make these 3 or 4 comments and stop. The other question was, in your introduction, it was said that you were a scan trainer. So my question was, do psychiatrists come for scan training? Because several years ago, I was also a scan trainer. And I was trained by the late Professor John Wing himself, along with Terry Brewer and others, when scan was being developed. In India, I don't think anybody uses scan these days. They use much shorter, quicker. I don't like it. Scan is the kind of, assessment, structured, semi-structured assessment that we are all trained to do. That was my question. And if at all any psychiatrists come, why do they come for this training? Are they researchers or do they get funding only? You don't have to answer this. I've raised these things only just for my. Then I have also put in the chat box As you were talking about Norway and all that, where people were being treated without antipsychotic medications. I remember in 2002 in the British Medical Journal, there is a paper by Dr. Venkateswaran, who did MD in NIMADS under the supervision of Dr. Raghuram. And I remember this not only because it came in the BMJ, British Medical Journal, but it produced a lot of debate all over the world. This was a group of people with psychosis who were being treated without medications, compared with in Tanjore in a temple. And then a group of, it's a well-conducted study, otherwise you wouldn't have got it published in the British Medical Journal. And why I remember it is, it had to be cleared in the ethics committee, although it was an MD thesis. Sydney may or may not remember because Sydney had not joined as a faculty in NIMADS. I'm talking about 2002. So there have been tradition of treating people without antipsychotics, even when they have come to psychiatrists, just for the information. Well, of course, in Norway and in Finland and all, it has come more as a movement from the carer, user movement, etc., etc. I want to conclude by saying that she was very kind enough to say that this has been an Australian innovation. She mentioned about Pat McGorry. And since in the last many years, I have spent part of my time in Australia, I'm very proud to say that this is, of course, an Australian intervention, because she said that it started as a, treatment service approach, but then became a mission. And the person who drove that mission was Pat McGorry. But incidentally, I must tell you that this is not the first or the only Australian contribution to global psychiatry. Since Professor Chakraborty works in Leicester and UK, the first major contribution was Professor Aubrey Lewis, who trained, in fact, people like Michael Shepard and John Wing and a whole generation, of teachers in British psychiatry. Aubrey Lewis is a student of the Adelaide Medical School. He chose to move to England from Australia, and he became the chair. Is Professor Sir Aubrey Lewis. That is the first thing. But I'm sure all the people in the audience will remember about who first used lithium carbonate, which is now the gold standard for treatment of bipolar affective disorder. It was John Cade in Melbourne, much before, at least 30 years or 40 years before Pat McGorry propagated first episode psychosis, John Cade. So I usually say there are 4 contributions: Aubrey Lewis, John Cade, lithium carbonate, Pat McGorry. And the latest contribution to global psychiatry is Helen Herman. I don't think she is in this because this is Thursday musing. Musing's a purely Indian kind of a thing. So Helen will not be there, but Helen Herman was the president of the World Psychiatric Association. I would conclude. Thank you for asking me to speak. Thank you, Professor Chakraborty, for an excellent, very balanced talk, lot of information. I would like to I have noted some of the references, but you have very kindly agreed to provide to the organizers a list of references, and I would like to get a copy of that. Back to chairpersons.
Thank you so much, sir. Thank you so much, sir. Amrit, should we take some questions from the chat box?
If I could respond to some of Professor Isaac's comments over there. So I'm going to start with actually the mention about SCAN. And like many people who have trained in India and in CIP, we know that when we started psychiatry training, we would be handed our fish, we would be handed our SIMS, and we would be handed our SCAN glossary. That was the absolute funding in psychopathology. And by generations, we would get those photocopies of SCAN questionnaire and booklet and of the glossary, and with all the list of people involved over there, Terry Bruher, Dinesh Bhugra, all the names you would see over there. And then when I came to Leicester and interviewed for my first job as a trainee in 2007, Terry Bruher was on my panel. And I must say I was a bit starstruck I'm being interviewed by Professor Bruher. And then as time progressed, I said, Leicester is actually the only active SCAN training center in the UK at the moment. London also trains, but they train only their research people. And in 2009, I took over the organization of the SCAN training in Leicester. And one of the first things when I got into Leicester was telling Terry that I wanted to be involved in scan training. So I started by helping out, then took over the organization. I'm now the lead trainer, and I've been with Terry to several international scan panels. And the breaking news is we are working on version 3 at the moment. So the version 3 is almost near publication, hopefully by the end of this year. The main change will be that it will have a chapter on neurodevelopmental disorders. So ADHD and ASD is going to be part of it. Just a story to share. It was at one of these panels during a coffee break that Terry came up to me and said that, Nandini, I'm sure when you were in India and you would see those scan questionnaires and manuals, etc., and you'd think that, you know, this was produced in some hi-fi center with lots of, you know, very, very intelligent people. Actually, it's a couple of people around a coffee table. And that comment has never left me. Terry is a very, close friend and mentor. I hold him in very, very high regard. And some of the insights and comments he's given to me in terms of, you know, how you build your passion in psychiatry and career have been massive. And I don't consider myself to be academically brilliant. I honestly don't. I have my areas of passion and interest, and I try to keep up to date with that. Scan is a great passion of mine, and what I've tried to do in Leicester and within the UK is publicize it as a document for good clinical practice. This is not just for research. So yes, we do have many, many psychiatrists who come to the panel. But we also train the adult psychiatric morbidity survey interviewers. And in the last 2 years, we've done some remote training where we have had people from India as well. Yeah, and we've had overseas people. So that's all about SCAN and, to talk about my involvement there. In terms about what age we take on, until 2016, the service criteria for early intervention in psychosis in UK took on people between the age of 16 and 35. Now from 2016, we changed the criteria to 16 to 65, so the entire adult age range. And we are commissioned to take care of people until 3 years. So 3 years of presentation to services, irrespective of the duration of untreated psychosis before that. And we have a couple of publications as well about that. And what we find is keeping people on longer does not improve their prognosis. So sometimes we are stuck with people. We end up keeping them for more than 3 years because they cannot be discharged back to primary care. They are still quite unwell. They need forensic or assertive outreach services. And by the time they've been discharged from us, they have spent 5 or 6 years with early intervention. If they are poor prognosis, it makes no difference in their care. So if they are to get well by 3 years, go back to primary care, that happens automatically. If they don't get better, if they need longer, it just continues. In terms of, does the advantage of early intervention die out once they are discharged? You're absolutely right, Professor Isaac, that there are again political views of early intervention services are not worth the money. There are absolutely as strong views about, yes, we are value for money, we are the most ethical psychiatric service out there. And what we find is that I think for a section of people, we bring a more human touch. It's very difficult to always prove everything by money and recovery rates and hospital admissions. But I think, there can be, if we look at a wider range of people returning to work, taking less time off sick, that kind of economic analysis in society, then probably we can prove our worth better. Those were the two comments I wanted to make. There was something else I wanted to make, but I think that slipped my mind at the moment. But I think I've spoken enough. If there's any other questions to come, thank you.
And one question, the patient, again, you have actually answered it. Patient and family come to my OPD and they ask, ma'am, how long should I take medication?
Yeah.
So what do I say? This is the first episode. How long should I take? Patient
Okay.
has recovered now. Why should a patient take the medication now?
Okay. So the simple way I try and explain to them is that, yes, I understand the impact of stress. I understand if there have been impact of drugs, etc. I understand that your life is better now. But these things cause a chemical upsurge in the brain. And the psychosis is this chemical upsurge in the brain. And everybody's chemical upsurge has an individual duration. And when I give you medication, it calms down this upsurge. And at this point of time, I can't tell you whether your natural cycle has resolved on its own or whether the medication is just covering that upsurge. So if I continue the medication for at least a year, I know that I have covered the maximum cycle length of an acute episode. If it was just a transient episode, that's the way I try and explain to them that at this point, the fact that you are better might be two possibilities. It might be that you are well, and if we stop the medication, nothing would happen. But it might be that there is still an ongoing cycle, and that is just being covered by medication. And if we take off the medication, we are not going to take it off suddenly. We are going to go down gradually so that if the illness is still continuing, if it comes back, it's not going to come back with the force of a cannon, that we'll still have time to roll back and settle things. And I tell them that if we stop the medication and the symptoms come back, or if you start wobbling even when we are reducing medication, then it's nature telling us that you need to be on medication for longer anyway. How long? For life seems a very harsh thing to say. So my favorite phrase over here is for the foreseeable future. The hope I give them, and I think that is a very realistic hope, that research is always happening. You know, research is going to put in new cures. We could never have predicted where we have reached in the treatment of psychosis 100 years ago, even 50 years ago. So what will happen in another 50 years, in another 30 years, we don't know. So at this point of time, I say you need to be on medication for foreseeable future. If anything happens in the next 10 years, which means you can come off medication safely, that's something to keep out hope for. So that's my usual spiel.
Okay. Thank you, ma'am. Thank you. So, no, suppose as a doctor, I want, suppose, let me just be the devil's advocate. I want to give the patient as long medication as he can, probably lifelong. So at what point of time I'll be hurting the patient rather than helping the patient? Suppose I suggest you have to take lifelong. So what is that transition zone when the beneficial effect of medication is less and the negative effect would be more? What zone, how to catch that zone?
I think it depends on the side effect versus efficacy. And what, you know, the newest medications that have come into the market, we don't know what they're going to do in 30 years, 40 years time. Yeah, with the older antipsychotics, we know about tardive dyskinesia, etc. With the newer ones, we are still learning. So in terms of, you know, whether it's more harmful or useful, I would go with the efficacy versus side effects that I see cross-sectionally at the moment. But I wouldn't be able to give a time period to it that if I give them for more than 20 years, at that point it crosses over. No, I think it's very here and now and what we see in front of us. It's something like I might give them a lower dose of antipsychotic, but that means that they will still have a few voices, but they are manageable, but it means that they can still go to work. And it might be that I give them lots of medication and yeah, it dampens down all the auditory hallucinations, but it means that the patient can't get out of bed in the morning. So you've got to have a little bit of a compromise that, okay, maybe you'll have a few residual symptoms, but it means that you can at least go to work.
Okay, thank you.
I'll be speaking from the other end of the spectrum. Now, if tomorrow somebody sues you for not starting antipsychotic, for stopping the antipsychotic too early,
Okay, as long as we have documented our discussion with the patient, right? If I'm not comfortable stopping an antipsychotic, if I'm saying that, you are a voluntary patient, I am telling you that you need to be on an antipsychotic for a year at least to make sure that you are stable. And actually, you don't stop the antipsychotic if you're uncomfortable, it's the patient who stops it. You're not stopping your prescription. The patient's just saying, I'm not going to go to the pharmacy to pick it up. In terms of, let's say you go for a year and after that you stop it. And after that, the patient relapses. As long as you have documented that what you have done is evidence-based, risk and benefits, there's never a guarantee to risk-free treatment anywhere. So, as long as the documentation of, and that's where you've got to get the patient on board of what you are doing and say that these are your choices, though that's difficult to do in an Indian scenario. People still expect us to give them the full answer. But then if they don't want to listen to us, I would clearly document that this was against medical advice and the patient does have to bear responsibility for it.
The patient might ask you why you started the open dialogue with me. I am having psychosis. You just offered me the antipsychotic. What about the other theories we are talking about? Suppose the Soteric paradigm or the open dialogue or whatever. Why did you give me that choice? I was not in a condition to.
Well, the patient should be actually quite well before they are saying that. For somebody to come up and say that, I should have been
because you give that option to 100 people, 99 will tell that we don't need medications. If it is psychosis, if it is schizophrenia, if it is.
I think when you're talking about somebody without insight, that's my criticism of those papers. When you're talking about a patient who is clearly without insight, forget antipsychotics. They're not going to accept any therapy, any open dialogue. They don't think they need professionals at all. A patient who is actually coming up and saying, I need treatment, I would look at their diagnosis of psychosis with a tiny bit of query.
Ma'am, there are many patients, I think more than one patient, they were initially on very minor doses of antipsychotic and stable. They stopped, and when they relapsed, they had to be on huge doses to get control. What is the experience of the panel on that? Initially controlled on very, very small doses and stopped, relapsed, and then huge doses required.
I don't think the dose, sorry, go on.
I'll just answer this and then I'll ask Nandini to answer further. In Nimanj, when I was there in 81 and 83, we used to see the old records. Believe me, most patients, that is, I'm talking about 66 onwards, the records, when the old patients are there in the wards or when they come for a follow-up, they were on 25 milligrams of chlorpromazine, HS, BD, or TID. And when we were there in 81 to 83, our dose range was 300 to 1000. So that is one aspect. I mean, we talk about the practices we have. The second thing I think is each patient is different. And to just close my argument, I am seeing patients from 87, and luckily because I'm a single consultant director with a team working with me, I have one patient who is on 900 milligrams of clozapine with the blood level still hovering only around 300. So each patient has a different biochemistry and biology, and especially our schizophrenia patients with having smokings. I think pharmacokinetics of the drug and the body of the individual matters, and the psychosis. We really don't know what's happening even today. We know there is something going wrong. To that extent, we have a lot of experience. That's why I would request Nandini to answer further.
Actually, this point about with every relapse, the need for the amount of medication needed goes up and the maintenance dose also goes higher, is something that I highlight to the patients when we are worried about taking medication off. And sometimes it's, practical. Somebody's come to me with a 7-year history of very, very, of being really unwell. It's taken a year to get them back to normal functioning. For them, I don't even go into that 70-80 statistic. I mean, I tell them the 70-80 statistics, but I tell them that you've been unwell for 7 years. Do you think that treatment after 1 year, taking you off medication, is even worth going back to what you and your family were going through? And one of the risks I do highlight over there, that if you relapsed a second time, we might not be able to bring you back to the stage that we see you now, or it might require higher dose of medication and definitely higher dose of maintenance dose. So it is worth, highlighting that we've got you to a maintenance dose, which is not giving you side effects. You can't even make out that you're taking the medication, 1 injection a month, 1 tablet a night. Really, is it that bothersome to the risk of relapsing, going back to hospital, going on higher medication, taking a chance that the medication might not even be effective a second time, with every relapse happening? So I think that's a risk factor to highlight to patients as well, and then let them make an informed choice. Yeah, but we are very much observed. I would agree, Aline.
Okay. Thank you, ma'am. Sydney, any comments from your side?
Yeah.
Thank you very much, Professor Nid. Really, what to call an enhancing experience. Very, very neutral, very, very clear where we stand. When Alim and Dr. Pati said that, can you be a chairperson for this session on Monday? I was a little struck. Okay, Monday and Wednesday, and I have just 3 days. So I was to look at what has really changed in the past 2 decades about, how do we understand psychosis, what was psychosis. Alim and Amrit, can I take the liberty to take maybe a couple of more minutes?
Yeah, the full house now. It's all yours.
All right. Okay. Yeah. First of all, there are a lot of interesting questions which ma'am's also answered, Prasad sir has also answered, and still we don't have a lot of answers. First of all, our diagnosis of whether schizophrenia is single or is it multiple. Yes, DSM-5 says it's single, DSM-4 says it was multiple, but when we look at the symptom, yes, when we are a student, when we were doing our MD or DPM, and when we are a fellowship, we need to learn, we need to follow criteria, and we tend to diagnose patients based on what ICD or the DSM says that was the gospel. But when we look further, sometimes we challenge, does schizoaffective really exist? So the conundrum is still unclear. When you say micropsychotic episodes, but when you say macropsychotic episodes coming every day but 1 month, then does it become schizophrenia irrespective of the course? Because that is what DSM and ICD says. So, well, when you look at all the evidence that has been there from 2006-7 to 17, and now, what I found is just going through some of the most recent meta-analysis. Some paper was released just a couple of months this year. We are slowly changing without, let's say, when we say open dialogue or the rights of the patient, yes, it is fully there. We respect that, but knowing the disease more better compared to, let's say, 20-30 years back, even though symptoms remains the same, the change has been, initially it was DUP or first episodes, maybe a year and a half. Then the Chinese and the Taiwanese came up with some research which suggests that perhaps it is good if we go 2 years. The latest one is very mildly saying it is going to be 3 years. Okay, then I was just trying to look at, okay, how has our understanding changed from, let's say, an epigenetic perspective? Pardon me for saying this, because I do a little bit of work, not quite a lot in these things, and from a neuroimaging perspective. And there was talk about, the DMN network was compromised, so antipsychotics helps, and it is better if we keep it for a period of time. The geneticist will say, okay, we are dealing probably with a disorder or a set of disorders or a syndrome where the cause is likely to be genetic. That means it is already there in the body when they are born, and it is the difference in the manifestation of the symptom which, when it happens, controlled by so many biosocial or stresses, as we understand psychiatry and our mental illnesses. And they answer one part of the question that, since it is already an genome, and you are trying to correct the genome and the proteins and the with us due to medicine. So medicines are required lifelong. It sounds very nice. Please call it a self-critic to myself because we also work there, but it does not answer the whole story. When we look at the diseases like schizophrenia, bipolar, we are not talking about a single gene hypothesis. We are not talking about a one gene like a diabetes. We are talking about multiple candidate genes. I may be trained in BDNF, I may be trained in Relin, but I am not trained in GAD6 or so many other things. So I mean, when you are saying candidate, you are just talking about a couple of genes based on those ones. So does genetics answer all of it entirely? But they are beginning to. Then what is controlling the remission? There is an area which is still probably, I mean, most of us doesn't have it. But what I can conclude is, if we just take the history, I mean, there is where, like Dr. Mohan Isaac was saying, Nandini ma'am was saying, a very good history about whom we are dealing with. Prasad Rao has just said, everybody is different. We may not be able to provide an individualized psychiatry or a very, very personal medicine in a developing country like India, but maybe a very, very good history might at least give us a lead about how long are we likely to treat them. Multiple episodes, family history, risks, childhood adversities. We have to be very, very honest. This is what we hope will happen. Being trying to be very sweet, but you are likely to, go for a longer period of time. I think everyone will agree the most difficult question that we face today is when they ask, can we get married? We don't have a straight answer. We really don't. I mean, when you say can't, you are taking away something which is very a personal right. When you say can, then the law comes in and you are caught between both places. So I think it was a very interesting discussion, and maybe 10 years down the line, when I become a little bit older, we may have more knowledge and information, and probably by the time they may say, okay, treat lifelong, or there is a new molecule down the town which tries to look at a different pathway like endoxifen or something has come, but it is wishful thinking. But nevertheless, we are scientists, we are people of medicine, and keeping our options open and being honest, I think that might be the best way forward.
Thank you so much, Dr. Sin. It was
Dr. Alim,
wonderful.
Dr.
Yes.
Basudev sir is here. Can we just call him?
Yes, why not?
Director, Central Institute of Psychiatry and our teacher. Dr. Basudev sir. देखो ना unmute कर Alim.
हाँ कर दिया unmute. Basudev sir, you are unmuted now.
Yes, yes.
Sir, please put on your
Welcome,
video
Dr.
also, sir. I
Welcome.
want to see you, sir.
Just share your video, okay?
Thank you, sir.
Hello,
CIP, our
Vasudeva.
director.
Yes.
Hello, Dada.
Sir, please.
Nandini, excellent presentation as always. And this is really a very difficult area. And
Thank you.
lots of controversies exist. And you have beautifully brought all those things together. And let's see some of the things, how future unfolds, and whether we become more clear on about when to start, what to start, when to stop, how to stop, where not to start. So all those answers we get. Okay, thank you.
Thank you, sir.
Thank you,
for
sir.
coming
Thank you
and
so much, sir.
being part of this program.
Thank you, sir.
I think we'll hand it over to Tufan.
Yeah.
Tufan, sir?
Tufan, sir, your comments?
Thank you very much. We have had a very nice session about first episode psychosis. And as I take it, first episode psychosis is not necessarily acute psychotic episode. And if we take our perspective, the duration of DUT, which is quite high in this country, impacts the course of first episode psychosis. DUT can be as long as 2 to 3 years. And if any psychotic process is continued in the person for this time, and I have revived minimum 3 to 4 patients from their house being chained, all these 3 to 4 years. And assumed they had been psychotic culture. So this is the part one has to take into consideration. And second part which strikes to my mind is that all psychotic episodes, even if they are acute, even if they can be attributed to be ATPD, they do not take the same course throughout their life. There is a strict chance of change in diagnosis. Completely it may become some not non-schizophrenic disorder. So that has to be borne in mind. And one, as you told us, everybody, recording of the discussions is very important. Amrit was telling someone will charge, why did you stop my treatment? Someone will charge reversely, why did you continue my treatment? As per record, I was asymptomatic, I was going to office doing all the work. Why did you continue my treatment? And not that person, there are people who would incite for people to take those measures. So this is a difficult thing, and this needs much more discussion. And what are the markers to tell what is the course of the first episode psychosis? What are the biological aspects? What is the residence of the patient to face this adversity? All these things count. I think we can have another session to discuss all these matters. And it would be nice. But thanks a lot. Thanks a lot, Dr. Nandini, for your erudite presentation. And that's very nice. We had the participation of Dr. Prasad Rao. We had the participation of Dr. Bohun Isaac, Dr. Basudev Das. Thank you. Thanks everybody.
So I'll give a formal thank you. So first of all, let me thank Professor Nandini Madam, because we had thought that we'll be playing football and we had to play a game of baseball. So I think she takes the credit for that. Alim was thinking, should it be cariprazine? Should it be for 6 months? Should it be amisulpride? Should it be clozapine? Or should we, Tufan sir was thinking of a trifluoperazine. Prasad Rao sir was thinking of something exotic, but then, you floored everybody. And I think you managed to change the whole narrative, the direction of the whole, our thought process. Because now we are discussing whether we should start antipsychotic, how long should we start? I think, and that's a very, very brilliant effort on your part to make us think beyond what we expected to think. Thank you, Prasad Rao sir. It was a parallel presentation again. I would congratulate you for that. So it was Dr. Nandini and Dr. Prasad Rao today, and we are absolutely delighted that you were able to contribute so much. And we are, Dr. Sydney, my friend, he always tends to listen, and at the end he will throw all his cards at the same time. Thank you for summarizing it so well.
Thank you.
Dr. Tufan sir again asked a lot of questions, and I would like to, many of the questions which we had in our mind have not been answered, Dr. Nandini. So you have to come once again. It is your fault. It is your fault. No, it is her fault that she has to come again. It's a request on behalf of Thursday Musings that you have to come again and take care of the other part of the questions where Dr. Sydney was asking, where Dr. Tufan sir was asking, and many of the questions. So you have to answer. And to be honest, Alim could not ask any questions today, and that's a big dampener. So next time he will ask. He will be given a chance to ask. So thank you everybody. Thank you our musing team. We had more than 250 people logged in. That's a great effort on the 85th episode. Thank you to IPS OSB. Thank you Torrent. Thank you to all our people who loyally come and be part of this. Mohan sir is always there. Dr. Basudev sir was there. So we had a lot of people. So Mohan sir is now part of musings now. I consider him part of musings. So thank you, Dr. Mohan sir. Thank you to a lot of people who logged in, who asked a lot of questions.
Dr. Kamran is there. Yeah.
So good night. Next time we have a very interesting topic on deep brain stimulation. So in resistant OCD. So the Nimans team will come and speak.
Yeah.
We hope we'll have another blockbuster.
Next week is ANSIPS after that.
Next week is ANSIPS. So Alim will formally take over as treasurer on stage. So Alim, congratulations, and we'll meet next week. Thank you so much. Thank you, everybody. Good night.
Thank you, ma'am.
Thank you.
Really, it was a very nice interaction.
Thank you.
Thank you, Sydney. Now, sir, thank you so much.
Bye. Bye.
Bye. Bye. Take care. Have a great night.
Chintan. मीटिंग क्लोज करें सबके लिए।
Sir, may I end the meeting?
Close कर दो वरना खुल लो हम.
Sir, may I close the meeting, sir?
Sure.